distribute it to whoever is interested. So if you miss something or are confused by one of the slides, you can refer back to it in the future. So I'll share my screen now. Can you see it clearly?
Yes, we can.
Okay, great. So as was already mentioned, I'll be discussing the trends in contraceptive use and needs in Africa. But to be honest, this title is a little bit of a misnomer because I'll also be talking a little bit about the trends and needs in the world, so that we have a point of reference when we're discussing Africa specifically. So it's a basic right of all couples and individuals to decide freely and responsibly the number, spacing, and timing of their children. This idea was put forward in 1994 in Cairo at the International Conference on Population and Development. And this was a seminal meeting that shifted the discussion of family planning away from population control and lowering fertility to recognizing that this is also a human right and encompasses much more than just fertility, and that these elements have to be respected when we're trying to encourage people to consider using modern contraception. The United Nations Agenda for Sustainable Development is specifically interested in furthering the use of modern contraception and promoting reproductive and sexual health care. Target 3.7 of the 2030 Agenda specifically aims to ensure universal access to sexual and reproductive health care services, including family planning, information and education, and the integration of reproductive health into national strategies and programs. So you see, it's not purely about distributing contraceptives. That's not the only goal of sustainable development here. It's also about bringing information and education and providing people with the tools so they can decide what works for them. We know from the huge amount of research that's been done that access to a complete, affordable range of contraceptives can have many benefits for women, couples, and children. This can allow women and couples to choose the timing and the number of the births that they have. So not just lowering the number of births in a lifetime, but also deciding when those births happen, which is equally important. It can allow women to avoid high-risk pregnancies, whether that means shortly spaced births or births at older ages, or if a woman has some particular underlying conditions that makes her vulnerable to a pregnancy that she maybe doesn't want. It can reduce the number of unintended pregnancies and in turn reduce the number of unsafe abortions. It can also serve to promote the socioeconomic opportunities of women and their families by reducing the number of mouths to feed, for example, or allowing a woman to complete her education, or allowing a family to save more money for the future or to invest in themselves. And some specific methods of contraception can be used to reduce the transmission of sexually transmitted disease, such as HIV, which we all know is a particularly serious issue in parts of Africa. The thing is, though, progress in increasing universal access to family planning has been uneven between countries and also within countries. And there's current and emerging challenges that will need to be addressed to ensure that nobody is left behind in this ultimate goal of reaching sustainable development. So in this presentation, I'm going to first cover how do we measure contraceptive use so that you have an understanding of where this data comes from and what exactly we're talking about here. I'm going to discuss some definitions of the family planning indicators that we use and where we get the data on those indicators. I'm then going to discuss the trends and patterns of contraceptive use and needs that we find throughout the world in different regions and specifically within Africa. I'll then turn to how contraceptive use relates to sustainable development, which I think is a very interesting, there's a lot of really interesting relationships there that we can explore some of them, and maybe it will give you some further ideas for possible connections between contraceptive use and things you might not have ever thought of. And then finally, I'll wrap up with some concluding remarks and some further information. So first, measuring contraceptive use. We can imagine that the population of women in any country, the reproductive age population, consists of 4 groups. So here on the right, you see this rectangle I've created with, it's got 100 little rectangles within it. So let's say that's a population of 100 women. We can divide that larger population of women of reproductive age into 4 subgroups. First, we have women who don't use contraception and they don't have a need to use contraception. And I'll discuss what all these groups mean in a moment. Then we have women who do not use contraception, but they do have a need for contraception. Then we have modern contraceptive users, and then finally traditional contraceptive users. And the way I've set up this schematic, you see that you have a significant proportion of the female population of reproductive age, they don't have a need for contraception. And that's typical in most populations. And the second largest group, or equally as large in this case, is the number of modern users. And typically that is the largest group or one of the largest subgroups of these women. And I'll show you more real data in a bit on this. So when we discuss women who are non-users and they don't have a need for contraception, what does this mean? Well, it means a few things. First, it could be that they are not sexually active, in which case there's no risk of pregnancy, and it doesn't matter if they do not use contraception. It could be that a woman is not able to become pregnant, but from non-surgical means. So she, for whatever reason, has lower fecundity and simply cannot become pregnant, and she's considered to have no need. And then there's the majority of this group, which would be those who want to become pregnant. And if they want to become pregnant, they don't want to avoid pregnancy, so they don't have the need for contraception. The next group would be non-users who do have a need. So the distinction here is that these are women who are sexually active and they are able to become pregnant. But the key thing is that they do not wish to have any children or any more children, or they do not wish to have any in the near future. So you could have a case where a woman, she had her first birth and she does want to have another child, but she doesn't want to have one until 3 years from now, let's say. So she would be considered as, and if she wasn't using contraception, this would be a woman considered to have an unmet need for family planning. The next group, and one of the largest, is the modern contraceptive users. So these are women who are using methods such as the birth control pill, male or female condoms, IUDs, implants, injectables, hormonal patches, lactational amenorrhea, so using breastfeeding as a contraceptive method, surgical sterilization for either males or females, and then there's others as well, but these are the most common methods, I would say. And then finally, you typically have a smaller group in a population that is relying on traditional contraceptive methods. And these include things like withdrawal, rhythm methods or calendar methods, so trying to avoid the ovulation period, or various folk methods. And, basically every population in the world has some sort of folk methods. Typically, they're not very widely used, but you find them pretty much everywhere. So how do we measure contraceptive use and need? The main metric we use, the most basic way of measuring contraceptive use in a population is using something called the contraceptive prevalence rate. So this is very simple to calculate. If we refer again to this little diagram on the right, if we just want to know what's the contraceptive prevalence rate for the population, we would look at what's the number of modern users plus the number of traditional users, and just divide it by the whole female population of reproductive age. And this will give us the percentage of women who are of reproductive age who are using contraception. You could also do this a bit more specifically and look at what's the modern contraceptive prevalence rate. So then you're just looking at the modern users divided by the rest of the population, or you could do this for the traditional contraceptive prevalence rate. So where do we find all of our data to look at contraceptive use and needs throughout the world? Well, the answer is we have many different surveys. And they come from different sources, and these change over time. So currently, in our latest revision, we have over 1,300 surveys that we use to calculate contraceptive use and need. And this covers 195 countries or areas. So geographically, our coverage is quite broad, but this is not equal over time. So there are certain periods of time where we have better coverage of some areas than others. For example, in much of Africa, most of our data is much more recent. So especially since the mid-1990s or the 2000s. Whereas for countries in Europe, which are not as interested in family planning, a lot of our data comes from further back in time, like in the 70s and 80s, with a few surveys later on. So we have a kind of a mixture of data sources to collect this data. The most prominent is called the Demographic and Health Survey. These are done very frequently, every couple of years in a lot of countries in Africa, Asia, Latin America, some parts of Europe. And these are arguably the most reliable source. Then we have some other major survey series that have become prominent sources as well, like the Multiple Indicator Cluster Survey, which is administered by the UNICEF, and the Performance Monitoring and Accountability Survey, which comes from Johns Hopkins in the US. But then you see all these gray bars. These are all national surveys that are not part of a bigger series. So, we find that, let's say Egypt has conducted a survey on contraception in 1 year, and then we grab that one. So we have quite a mixture of different sources of information that we pull together to try to understand contraceptive use and needs. And this is a major challenge because different surveys collect information differently, and they have different approaches, and it's quite a lot of work to combine all of this information in a way that can be consistent across time and across geography, so that we can have some good benchmarks to evaluate current levels of contraceptive use. One major thing that's part of our work at the population division is that we have to account for the fact that not every country and year will have a survey that can be used to calculate contraceptive use and needs. So, for example, one country in Africa that's had quite a lot of of surveys done about family planning is Malawi. Ethiopia is another example. And you have quite a lot of data for those countries. But still, they're not annual data. You don't have it every single year. You might have it every 2, 3, 4 years. So we have these gaps we need to fill in. And there's many other countries that have much less frequent data than that. So to fill in those gaps, we basically use a statistical model that I won't bore you with, but it takes the information from these surveys and kind of, just fills in the gaps of countries that are missing data or years that are missing data, just so that we can have a better understanding of how things change over time. And you can explore all these data yourself. I'll have a link again at the end of the presentation, but we have a new data portal that we created. It's fully interactive. You can go on there and choose whatever country or countries you want, whatever population or family planning indicators you want, and you could create data visualizations just by clicking around, or you could download data if you want. So I would encourage you, if you're interested, to check out this new data portal. And like I said, I'll have another link at the end, and I'll share these slides so you don't have to write this down right now. Okay, now to the more exciting stuff. The contraceptive use and needs, trends and patterns worldwide and in Africa. So I showed you we have these different ways of looking at calculating contraceptive use and different metrics we can use. But generally, organizations that are interested in measuring family planning are interested in the use of modern methods, not as much as traditional methods. Why is this? Well, modern methods tend to be more effective and more reliable. And also, understanding the use of modern methods can give us a hint about the level of access and availability of reproductive health services in a population, while traditional methods can't give us any kind of information about that. Some traditional methods can be effective at preventing pregnancy, especially if they're practiced perfectly. Some can be quite highly effective, actually. But what we know from research on comparing perfect use and real-world use is that the real-world use of traditional methods tends to be less effective. So when you factor in the fact that people might not be so disciplined when practicing withdrawal or cooperative, then you find that maybe withdrawal isn't so effective compared to condom use, for example. And traditional methods typically require the commitment of both partners to be effective, which can create a conflict and can create barriers to success if avoiding pregnancy is the goal, while many modern methods only require the commitment of one partner, either the man or the woman. So the first graph I'm going to show you is the need for contraceptive for family planning by region. So when we talk about need, what this means is you remember I showed you this schematic of the population that's divided into 4 parts. So the need for contraception is basically the number of modern and traditional users plus the women with an unmet need. So it excludes the women who want to become pregnant or who don't have a need. So what we see here is that even in the most highly, even in the regions of the world that have the highest need for family planning, it doesn't exceed about 65%. And that's what I was discussing before, that you have this large population of women of reproductive age who they want to become pregnant, so they don't have a need, or they can't become pregnant, so they don't have a need. Since 1990, you've seen this dramatic increase in the total need for family planning in for instance, Latin America and Caribbean. But you've also seen a long-term increase from 1990 to 2020 in Sub-Saharan Africa and Oceania, excluding Australia and New Zealand, and to a less dramatic degree, but still an increase in Northern Africa and Western Asia. In the next, 9 years now, by 2030, we project that the need for family planning will continue to increase in Sub-Saharan Africa especially, while in most of the other regions, we're projecting kind of just a flattening out and a constant level of need. Of course, these things can change. These are just projections based on current data, but every time we get new data, these projections are updated. So we'll see in the next revision how this looks. So here, I've broken down those components of need by region, and this is for the data for 2020, just so you have an understanding of what does need mean in these different contexts. So on the left 4 columns, that's making up Eastern and Southeastern Asia, Australia, New Zealand, Latin America, and the Caribbean, and Europe and North America. The level of unmet need is fairly low as a percentage of the total demand. So of all the women who have a need for family planning, about 10% have an unmet need. The majority, over 80%, are of those women with a need for family planning are using a modern method. As we move further right on the graph, and we turn to the situation in Africa, in Northern Africa, Western Asia, and Sub-Saharan Africa, we see a different situation where still the majority of women who have a need for family planning do use a modern method. So in Sub-Saharan Africa, that's 55%. In Northern Africa, 63%. But you have a much bigger portion with an unmet need. So those are the women, again, who want to avoid pregnancy but are not using contraception. In Sub-Saharan Africa, that's nearly 40%. And in Northern Africa and Western Asia, that's over 20%. So there's a significant proportion of women who whose needs have to be addressed to help them avoid unwanted pregnancy. You also see that, interestingly, in Northern Africa and Western Asia, you have a much higher reliance on traditional contraceptive methods than you find anywhere else in the world. Whereas in Sub-Saharan Africa, the reliance on traditional methods is quite low, actually. It's lower than in Europe and North America, and it's on par with what you would find in Eastern and Southeastern Asia, for instance. So here we have modern contraceptive use by region over time. And so now we're looking at, this is that calculation I showed you earlier, where it's the number of modern contraceptive users divided by the total number of women of reproductive age. And we've seen a really dramatic transformation in Sub-Saharan Africa since 1990 until today, where in 1990, less than 10% of women between the ages of 15 and 49 used a modern contraceptive method. By 2020, this was over 20%. So it's more than doubled during that period. And it's been a general trend throughout much of the world to have these increases in modern contraceptive use. You see it in Northern Africa as well, to a lesser extent in Oceania. The most dramatic change was in Latin America and the Caribbean between 1990 and about 2010, where it increased very, very quickly. And then other regions that already had high levels of use, like in Europe, in Northern America, Eastern and Southeastern Asia, and Australia and New Zealand, where there hasn't been much change because there's only so much that this metric can increase. Because, as we've said, there's always going to be some significant proportion of women who want to become pregnant and don't need a modern method. Here I have the same graph, but I've only shown the different regions of Africa, and it's quite interesting because you see, in some ways, big differences, and in some ways, real similarities throughout the continent. The most obvious difference is that in Southern Africa, the level of contraceptive prevalence is much, much higher than the rest of the continent. And there was a very rapid increase in contraceptive use from 1990 until the mid-2000s, and then it kind of flattened out. In the rest of, and then the next interesting thing is in Eastern Africa, where you had this, there was an increase in contraceptive use from 1990 until the mid-2000s, and then it really sped up, and there suddenly was a lot more increase in the number of users of modern methods from the mid-2000s until the mid-2010s, and it's still increasing. And throughout the continent, in every region, we've had this consistent increase in the percentage of modern users over the past 30 years, and it seems like it's going to continue to increase over the next 10 years as well. Here, we dig in a little bit deeper into what specific methods are being used in the different parts of the world. So here, this is what we call a method mix. And this refers to what types of methods are used by contraceptive users and what is the distribution of those. And I really like this graph because I think it shows how differently contraception is applied in different parts of the world. And many things influence this, whether it's legal restrictions or new allowances, or if it's investments from foreign aid, or just purely culture. There's many different factors that can influence the contraceptive patterns within a region. So in sub-Saharan Africa, more than any other region, there's a much larger reliance on implants as a form of contraception. The closest you find to that is in Australia and New Zealand. You also find in sub-Saharan Africa and Oceania a large reliance on injectables as well. So just in sub-Saharan Africa, sterilization, IUDs, implants, and injectables make up over 50% of the users of contraception. When you look at Northern Africa and Western Asia, IUDs, on the other hand, are much more prevalent. Whereas in sub-Saharan Africa, IUDs don't make up such a significant part of the method mix. And that's this orange bar on Northern Africa and Western Asia. But like we discussed a little bit earlier, in Northern Africa and Western Asia, you also have this very large, significant portion that are using a traditional method, withdrawal. Whereas in sub-Saharan Africa, this is a pretty minimal share of women who are using withdrawal. Then you compare these to, let's say, Central and Southern Asia, where you have an enormous share of women who are using female sterilization as the main form of contraception. And I believe this is due to, there was a lot of pressure there's a lot of pressure coming from the family planning movement, especially in the 70s and 80s and 90s, to reduce fertility, especially in places like India, Bangladesh, Nepal. Where there was a lot of coercion and just pressure in general to limit the number of children being born. So it's very unusual compared to the rest of the world how much sterilization is relied on. Australia and New Zealand, on the other hand, by far has the largest share of women relying on male sterilization. There's no other region that has such a large percentage of women using male sterilization to reduce their risk of becoming pregnant. So I thought this was just a very interesting graph to show you about the different ways that women can satisfy their needs, so to speak, of avoiding pregnancy. So this final graph of this section is discussing unmet need for family planning and how Africa fits into the global picture. So to remind you again, unmet need for family planning is when women do not wish to become pregnant and they're able to become pregnant and they're not using a form of contraception. So in 1990, the worldwide percentage of women who had an unmet need, 22% were in Africa. So 1 out of 5 women were in either North or South Africa. But over time, this share has been increasing. So by 2000, 1 in 4 women who had an unmet need in the world came from Africa, and this has increased to 1/3 of women in the world with an unmet need being found in Africa in 2020. And based on current projections, we're expecting that it will be close to 4 out of 10 women in 2030 with an unmet need being found somewhere in Africa. So this is due to several things. So basically, the 2 major factors are you have uneven population growth throughout the world, which we'll discuss in a bit. Africa in particular will be growing faster than other parts of the world for the foreseeable future. And the fact that there are simply higher levels of unmet need in Africa than there are in other parts of the world. So these 2 factors will lead to this shift. And it kind of points to the importance of, if we want to tackle this issue at a global level, of focusing our efforts on Africa even more. So now I'm going to talk about contraceptive use and how it relates to population growth. So many of the populations where the rate of contraceptive use is increasing the fastest are also the populations where the number of women of reproductive age is growing the fastest. These tend to be populations where the rate of modern contraceptive use is relatively low, such as those found in Sub-Saharan Africa and Northern Africa and Western Asia. So this graph shows us the projected population increase from now until the end of the 21st century, and how each region will be contributing to that increase. So right now, every region in the world is contributing to the growth of the global population. The smallest contribution is coming from Europe and North America, or actually Oceania and Australia, but as well as Europe and Northern America. And the largest is coming from Central and South Asia, as well as Sub-Saharan Africa. Now, as time goes on, we see that as these bars on the start to fall below 0, that means we have negative population growth. So Eastern and Southeastern Asia, those populations will begin to shrink, actually. And as time continues to go on, more and more regions fall below this 0 line. So that means more and more regions are shrinking in terms of their population size. And we see that basically by the middle of this century, we're projecting that almost all of the growth in the global population will be coming from Sub-Saharan Africa and Northern Africa and Western Asia, but it's mostly projected to come from Sub-Saharan Africa. And I'll discuss the implications of this in a bit. So we've seen in the past 20 years and projecting to the future, we've seen that the number of modern contraceptive users has increased throughout all regions of Africa. The largest increases in terms of pure number of users has been in Eastern Africa, where in 2000, there were fewer than 10 million women using a modern form of contraception. And by 2020, this had reached over 30 million. And by 2030, we are projecting that about 55 million women will be using a modern contraceptive method. So this is an increase of what, over 5 in 30 years. But we've had the same trend happening throughout the continent. We've had it in Northern Africa, where there was about a doubling of the number of users from 2000 to 2020. And we're not expecting quite as large of an increase in the next 10 years, but still an increase. In Western Africa, where the number of users is projected to basically remain at a constant rate. So we've had more than a doubling of the number of users each 10 years, or between 2000 and 2020, and projected doubling by 2030, and the same for these other regions. So it's a consistent trend that throughout Africa that the number of users has increased and will continue to increase over time. So we did some calculations to try to figure out how does the number of users, how will the number of users be influenced by population growth, and how will it be influenced by other factors, such as the increasing uptake of modern contraception. And what we found was that the influence of population growth is really huge throughout Africa and Oceania. In Sub-Saharan Africa, we're projecting that there will be a 60% increase in the number of users, modern users, by 2030 compared to 2020. And more than half of those number of users will simply be the result of a growing population. So there's more babies being born, and as those babies eventually reach reproductive ages, they will be added to those numbers of users. So that has nothing to do with growing rates of use, just purely the number of users. The same can be said about Northern Africa and Western Asia, where about 2/3 of the change in the number of users will be due to population growth, while the rest will be due to actually increases in the rate of use. In other parts of the world, you find quite different situations. In Europe and Northern America, actually, the aging populations there will reduce the number of users, while maybe increases in use in terms of the rates will increase the number of users. And in Eastern and Southeastern Asia, where you have the most rapidly aging populations, you will see a decline in the number of users because of population growth, or population decline in this case. In order to continue to increase the number of modern contraceptive users, there's going to be greater efforts needed to meet the needs of these rapidly growing populations. And there's going to be lots of different areas that need to be focused on in order to continue to meet these needs. Governments will need to train and equip greater numbers of healthcare workers who can administer sexual and reproductive healthcare services and contraceptive methods. Governments will need to adapt their public financing to allocate appropriate amounts in their budgets to these specific areas, and to make sure those allocations are executed and actually spent on what they're intended. They're going to also need to be creative in how they go about procuring the necessary supplies and human capital and intellectual capital to implement these programs. Governments will need to develop supply chain management systems to avoid to efficiently distribute the commodities that are necessary to different parts of their countries and populations. They'll need to build logistical infrastructure so that we can avoid stockouts. So that, you go to a pharmacy and all of the birth control pills are not gone, and to support mobile outreach service delivery. So actually bringing the services to those hard to reach places or directly to the communities that need them. They'll need to invest in program management and administration. These are kind of the boring facts about a family planning program, but they're so crucial to a successful program, that you have people who know how to run them and who know where to look for guidance and so on. And for the future, to incorporate digital technologies for service delivery and support. So many people have these technologies at their fingertips, and these can be leveraged to take advantage of these technologies so that we can successfully deliver the services that are needed. Okay, in this section, I'll be discussing how contraceptive use relates to sustainable development. The United Nations has recognized the important role of modern contraception, and it's actually included under Goal 3 of the 2030 Agenda for Sustainable Development. Goal 3 is to ensure healthy lives and promote well-being for all at all ages. So this is a very broad, all-encompassing goal, covering health for those who are most vulnerable at the youngest ages, like neonates and infants and children under 5, as well as the elderly and everybody in between. And one of the targets of this goal, target 3.7, is by 2030 to ensure universal access to sexual and reproductive health care services, including for family planning, information, and education, and the integration of reproductive health into national strategies and programs. The way, the Sustainable Development Goals are really focused on having measurable indicators that can be used to track their progress. And one way we track progress for this one, target 3.7, is by using this indicator called the proportion of women of reproductive age who have their need for family planning satisfied with modern methods. So what is this indicator? Well, it's quite similar to what I've shown you already. We return back to this nice schematic of our fictional population of women. And this indicator measures the percentage of women with a need for family planning who are using a modern method. So all that means is we are taking the number of women using a modern method and dividing that by the number of women with a need. So we exclude all those women who don't have a need for family planning because for them it doesn't really matter. But it's really, we're focused on, of those women who have a need, how many are using a modern contraceptive method. And this is important because it gives us some more precise information about access and availability of modern methods when a woman wants to avoid pregnancy. So it's a little bit more informative than if we just divide by the total population of women, because you never know, populations are different. So maybe in the population of Ethiopia, they have a different percentage of women who want to have a child compared to South Africa or Egypt. So this kind of standardizes our measurement and allows us to compare between groups. So for this indicator that I just described to you, there's no explicit numerical target for how much of the population should have a need satisfied by modern methods. Even in countries where modern contraception is widely available, it's accessible, it's affordable, even in those countries, the proportion of demand satisfied by modern methods isn't 100%. There's nowhere in the world where it's 100%. And this is for a number of reasons. there's many reasons why women may choose not to use a modern method. It could be inconvenient, or it can cause side effects, or there can be a fear of side effects. This side effects is one of the major reasons throughout the world why women discontinue using specific methods, especially you could imagine hormonal methods that impact the body much more. They might have a perceived low risk of pregnancy, so they feel like, you know, they're not at much risk, so why use a method? They could have infrequent sexual activity. So it's not that they don't have any sexual activity, but maybe it's very rare. So they feel, why, you know, it's also a perceived low pregnancy risk. There could be religious or ethical beliefs of the woman or her partner that are against modern methods. Or there could simply, you know, it doesn't even have to be so complicated. It can simply be a preference for traditional methods. So there's many different reasons why you wouldn't reach 100% of demand satisfied with modern methods. So at the population division, when we discuss this indicator, you know, since there's no real target, the way we kind of classify what's a high level versus a low level of modern of proportion of demand satisfied with modern methods is to say that more than 75% is high, less than 50% is low. But, you know, these are just a general rule of thumb. This is not something set in stone, but just for your reference. So here we can see the world map of this indicator, the demand for family planning satisfied by modern methods in 2020. And we can see some obvious regional differences here. In some parts of the world, the level is very high. Parts of Latin America and the Caribbean, China, Europe, North America, Australia, some parts of Africa as well. And we typically find the lowest levels in the middle of Africa, and basically it's this band running from Southwestern Africa to Northwestern Africa. But the countries that are a little bit spread out from that band are tend to have higher levels. And you also find some pockets with low use also in other parts of the world, in South Asia, for instance, and even parts of South Europe. Like many SDG indicators, increasing the availability and accessibility of modern contraception is not just an end in itself, but it can also support and be supported by the progress of other SDG indicators. So for example, we can support the adoption of modern methods in a population by focusing on some of these other SDG indicators. For example, making efforts to improve women's autonomy in decision-making, especially regarding sexual relations, contraceptive use, and reproductive health care. This is SDG 5.6.1. We could increase the coverage of essential healthcare services, and we could increase the proportion of national and local government seats held by women so that women's issues have a greater voice at the table when making policies. So this is a graph that shows us the relationship between decision-making on sexual and reproductive health and reproductive rights, and the percentage of demand that's satisfied by modern method. And this is a really interesting graph because it shows us, we don't have data for the whole world on this specific indicator 5.6.1, but it shows us that for those countries where we do have data, there's a clear relationship here where when more women are free in making their own decisions on sexual and reproductive health and reproductive rights, they are more likely, those populations are more likely to have more women use modern contraception. And the inverse is true. When there's fewer women who have these freedoms, they're less likely to use modern methods. And this relationship is especially strong in sub-Saharan Africa. If we had removed all these other colored dots and just left sub-Saharan Africa here, we'd see it's really a much stronger relationship, actually. In this graph, we're looking at on the x-axis on the bottom, going from left to right, we're looking at the proportion of seats held by women in national parliaments, and again, comparing it to the level of demand satisfied by modern methods. So we have a lot more data for this indicator than we did for the other one, and it's a little bit more messy than the other one. But again, we see that generally in countries that have a greater female presence at the government level, we tend to find that modern contraceptive use is higher. Now, of course, these aren't causal relationships. We can't say it's definitely causing this relationship, but it's an interesting association we find here. And by increasing modern method use, it can also help to affect other parts of the 2030 agenda as well. So increasing modern contraceptive use can help to reduce maternal mortality. It can help reduce preventable infant and child mortality, reduce the incidence of stunting and wasting among children under 5 years. It could ensure that all boys and girls can complete primary and secondary education, and it can reduce the adolescent birth rate. And it can affect all sorts of other things, but these are just a few examples. So here, when we compare now on the bottom, on the left to right axis, this is the percentage of demand satisfied by modern methods, and on the left vertical axis, it's the maternal mortality ratio in all these different countries in the different regions. And we find a consistent pattern in every region of the world that when you have a higher share of the female population using modern methods, there is a lower risk of maternal mortality. The relationship is stronger in some regions than others, but it's present everywhere. And this makes sense because this is a more direct connection than some other indicators. We would expect that modern contraception helps women to avoid high-risk pregnancies. This could include shortly spaced births, births at high ages, births at high parity, so having your 5th, 6th, 7th child, and births to women who have some underlying conditions. By having accessible modern contraception, we can avoid those high-risk pregnancies and lower the risk of maternal mortality. We also see that higher levels of modern contraception are associated with lower levels of under 5 mortality. So the number of children dying per 1,000 births. When the level of demand satisfied by modern methods is less than 40% or even 50%, the under 5 mortality rate is over 50 deaths per 1,000 births. When we move to the right of this graph, just by increasing a little bit the percentage of demand satisfied, this is almost cut in half. So in populations where the demand satisfied is 50 to 60%, the under 5 mortality rate is 30 per 1,000 births. And obviously it gets lower and lower as the level of demand satisfied increases. Now, again, these are not, this is not a causal claim or anything, but it's an interesting association that has a plausible theoretical connection by reducing, especially reducing the percentage of short birth intervals and increasing breastfeeding time. These can have an impact. And not surprisingly, we also find, oh, somebody has a microphone on. So, not surprisingly, we also find that as the level of demand satisfied by modern methods increases, we find lower and lower levels of adolescent fertility. adolescent fertility. So the number of births per 1,000 women aged 15 to 19. And this should be the most direct link of all, because obviously contraception is related directly to fertility. But this just shows you kind of a few examples of different ways that modern contraceptive use can impact other things. So I'll just wrap up now with some concluding remarks to sum up the whole thing and give you some more information. Countries must ensure that a full range of contraceptive methods and services and information are available, accessible, and affordable to all. And these are crucial elements, because just buying a bunch of contraceptive commodities or having a few clinics is not sufficient to address the needs of a population. These have to be accessible for everybody, and there can't be price barriers. Otherwise, we're going to get uneven progress, where the wealthiest are able to control their pregnancies the most, and the poorest aren't. And this is just going to exacerbate other inequalities in health and economics. By doing this, we will support all women and couples to freely choose the family planning solutions that work best for them, and to do so with full information and without coercion. Like I mentioned earlier, we don't have a numerical target for modern contraceptive use. And part of that is because, it's not the goal of sustainable development in general to force people to use methods just so that they comply to some target or that to lower their fertility. It's that we want everybody to be able to freely choose with the best information possible what works for them. And like we discussed in the last section, achieving this ambitious goal can have a significant positive impact on the well-being of women, children, and families. What's important, though, when we take this down to a more granular level, is to, think about what works and how to increase modern use. Throughout this whole presentation, we've been focusing on, at the regional or sub-regional level. But, when we get down to it, Africa is an enormous continent with many, many countries and populations in different situations. And there is no one-size-fits-all solution for every population. But here I just put forward a couple of ideas that come from the research on family planning programs, that show there's some consistencies across parts of the world and over time of things that have been successful in getting more people to be knowledgeable about different contraceptive methods and to use them if they want to. And this experience comes from places like South Asia, Latin America, Africa, Oceania. So it's really the global experience we could use to further our progress. So one thing that you notice in successful family planning programs is that the heart of them is at the community level. They use community engagement activities to try to spread knowledge, awareness, and eventually to encourage use. So these could include having group discussions, like we see here in this picture, where we have some either healthcare workers or some local women who are educated on family planning specifically to help foster discussions and help address people's fears and concerns, have radio programs that can serve as a mass media campaign to spread awareness, to have lectures from religious leaders. This has been a very important tool in many parts of the world, where you could imagine there's many places where people have strong religious and ethical concerns about contraception. And by recruiting religious leaders to the movement and helping them bridge the gap, this is very effective at convincing the rest of their population. and to have home visits of workers to help on a personal level, address people's concerns about contraception, because when it comes down to it, this is a very personal topic and something many people won't be comfortable discussing in public, for example. Another very successful approach is to recruit and train local health workers. And this has been so successful because you're able to get people to spread information and to deliver services who are part of the community, who understand the local norms. It's not easy to send, to some remote village somewhere, to send somebody from the US or Europe and try to convince these people that they should use contraception when they don't understand how people normally think about this issue or what's appropriate. So it's really crucial to train local healthcare workers. And you need commitment from the government, of course, at all levels, at the local, regional, and national level, such as, like I said earlier, allocating parts of the budget specifically for this issue, and to integrate family planning with other crucial health services. And I'll show you just now, I think in the next slide, an example of that. There's been some really promising experiences in parts of Africa, in specific countries, that have seen a dramatic increase in the modern contraceptive prevalence in the past 30 years. The most dramatic has been in Malawi, but also in Rwanda, Senegal, Ethiopia. These are all populations where the modern contraceptive prevalence rate has more than doubled, at least. In Malawi, it increased by a factor of 5 almost. And these countries have used a variety of techniques and approaches, and they all didn't use the same approaches. But here I've just listed a couple of the different individual approaches that were used that have been part of their success. So one thing, money matters, and significant domestic funding commitments and international aid has been a big factor in some of these countries. I think Malawi especially. Most of these countries have invested in skilled community health workers, especially women, local women. And again, this is because these women are especially able to bridge the gap of information and understand the local culture better than others. And they're able to earn the trust of others in their community, whereas an outsider might be viewed more skeptically. So they've built support with local and religious leaders. Some countries have heavily subsidized family planning services to make them cheap and affordable for all. Some have integrated family planning with HIV/AIDS and immunization programs, so that if you are going for a consultation about HIV, they'll also give you information about family planning as well, for example. And the last one here is having information campaigns that discuss the consequences of having repeated pregnancy on a woman's health. So these are just some examples of the elements of these programs, but obviously they were much more broad than these few bullet points. So right now, we basically sum up with, we have a current challenge and we have future challenges. Currently, the thing that's affecting the entire world is COVID-19, obviously. This pandemic has significantly affected the delivery of family planning services. So we've seen in different parts of the world, there's been stockouts. So like I said earlier, you just can't find the commodities you're looking for. You can't find pills or condoms or whatever because of supply chain disruptions. We live in a global integrated economy at this point, and if there's a disruption somewhere, it can affect many other places down the road. A lot of resources were redirected away from family planning towards COVID-19 treatment. So this has just left, fewer services available for family planning. It's also, there's been fewer facilities providing services, and those that do have limited capacity compared to before the pandemic, which reduces the availability of services. And the thing is, even though this pandemic, we hope, is a temporary disruption to the whole world, even when it comes to family planning, even a temporary disruption has a lifelong impact. Becoming pregnant and having a child, that's going to impact you for the rest of your life. So these are services that there needs to be efforts made to keep those on the agenda, even in the face of this global health threat we have. And the other challenge is this long-term challenge I alluded to earlier of population growth. Family planning programs will need to be scaled up, especially in sub-Saharan Africa, just to maintain the current levels of contraceptive use. So just to maintain that rate of use. But if you want to keep seeing further progress in these countries, more efforts will be needed. More resources will need to be redirected. More health workers will need to be trained just to maintain this high rate of growth. So this is the last slide, and this is just more information for you that you can look for yourselves. If you'd like to read more about our work on family planning at the Population Division, you can follow the link I show here. We have different publications and data sets available. Our most recent publication was last year. It's the World Family Planning 2020 Highlights. And this is just a PDF you could download and read through. And you'll see some of the graphs I used were from there, but there's a lot more information as well. So if you're interested, you could check that out. And finally, we encourage you to visit this new data portal because it's really user-friendly and you can find hopefully the answers that you want to look into more specifically. You could, if you're interested in data on your specific country, you can find that there. And again, I'll share these slides so that you can refer back to these links. Thank you very much.
Thank you, our speaker, Joseph Mollison. Doris, please, if we have any questions, please indicate by raising your hand. If you have any question, use the raise your hand button. Okay, I can see Dennis Karungi. Okay, Dennis, if you are there, can you open up and ask your question? We are now in for the question and answer session.
Sorry, that was a mistake, but I would like to find out in our family planning methods, how do we combat certain attitude?
Sorry, it was breaking up a bit. I couldn't hear so clearly.
Sorry, I hope you can hear me now. How do we combat negative attitudes among women? Are we supposed to force the family planning methods on them or find things that they can adjust to easily?
Well, it's a tough question. And honestly, we don't, at the Population Division, we don't do as much programming as we do kind of monitoring. But from reading the literature on different parts of the world on how they deal with this issue, a lot of it comes down to, it's not a satisfying answer, but it depends on the context, obviously. That's one reason why focusing on these local healthcare workers and especially women from local communities has been so effective, because if one common complaint is that if a woman is using a hormonal method, it's causing side effects and she doesn't like it, and it makes her body feel wrong in one way or another. And I mean, I suppose by discussing with them that, you know, these changes are from the hormonal methods are temporary, and that they're providing, you know, higher level of protection than these traditional methods. But I can't say for sure. It's quite, it's quite a, you know, that's such a personal conversation to have with somebody, and forcing, you know, you never want to force these things on people because it doesn't achieve exactly what you want. Like, you want people to be able to freely decide, because we see throughout the world, we see that when methods are available, the majority of women do choose a modern, reliable method. And it's not that there's a huge percentage of women who wants to use a traditional method, but there's always going to be some, I suppose. So I think forcing or coercion isn't really the best way to approach it.
Thank you very much. I hope your question has been answered. Dennis Karingi. Okay, any other person with your question? Okay, we have a question in the chat box, and I'll read it out. It says, I want to know, how can medical students contribute in sensitization? Sorry, if I understand well, if I forget what it says, sensitization. Sorry, can you? Okay, thank you. I want to know, how can medical students contribute in sensitization of contraceptive methods?
How they can, so does it mean to make people feel comfortable with them, or sensitization?
I think he means, how can medical students contribute in telling the public about these different contraceptive methods?
Oh, I think what's important is to have a good understanding of the different side effects that might be present, and have a good understanding of the pros and cons of the different methods. And, you know, people to just lay them out for people and tell them, like, you know, condoms can be effective. They're effective at preventing pregnancy and spreading disease, for instance, but they're less available. They're less, they require your partner to use them. So if he's not on board, then this is a challenge. Or an IUD is a highly effective form of contraception, but it might have hormonal side effects or physical side effects. It requires visiting a doctor for this. I think being aware of the different advantages and disadvantages is important, and just being honest with the patients, I suppose, providing them with these different scenarios and telling them these are the options. Nothing is without disadvantages, and and all of them have a certain advantage. But I think on that slide I had earlier, where I showed why do women choose traditional methods, if you think in those terms a little bit, so there's different concerns. There's side effects, there's inconvenience, there's perceived low risk of pregnancy. These are things that you can keep in mind when you're discussing the pros and cons, I suppose. Because, you know, nobody really knows, nobody really knows what their true fecundity is, what's their potential fertility. So if somebody says, well, I'm not likely to get pregnant, I mean, that's something you can address as a as a physician, saying, well, you don't know that you don't know that you're unlikely to become pregnant. So I suppose I would say that, to keep in mind these different reasons why women might not use modern methods, and think about the pros and cons of the different methods, and to just lay them out. And in the end, the individual woman or the couple, those are the ones who decide. Nobody else does. So that's all you can really do.
Okay, thank you very much. We have One B Joshua. Please, can you unmute yourself and ask your question? One B Joshua. One B, we can't hear you. Can you speak up? Okay, why One B is getting up? We have a question in the chat box. It says, I want to have, this one is from Kolapo Itunu. Okay, the question is, I want to have an idea of the traditional methods.
Mm-hmm. So the basic traditional methods are, the most common one is withdrawal. So that's basically if a man and woman are having sex, and then before the man ejaculates, he pulls out his penis, and then he doesn't ejaculate inside of the woman. So it's basically trying to avoid pregnancy that way. The rhythm or calendar method is a bit different. So that would be unprotected sex, and there's no withdrawal, but the goal is to, if you're practicing it correctly, it is to only have sex when a woman is not ovulating. So when she's at the highest risk of pregnancy, which is usually in the middle of her cycle, I believe, then don't have sex during that period. That would be the calendar method or the rhythm method. And then the folk methods are just very diverse. It's just one, it's a term for all of these different other methods, such as, you know, religious folk methods where you're using herbs or beads or something, you know, or prayers. So it's hard to classify that one.
Thank you very much. Any other question? Okay, I have a question here. It says, having said IUD is safe, coupled with some of its side effects, please, how long can one use it? Like, is it between 1 to 10 years? And is it changed or just a particular one?
Yeah, I believe the IUDs are good for 6 months or 1 year. You have to double check. I can't remember exactly. But so it's, yeah, I think they're inserted every 6 months to 1 year. And then they have to be removed and changed. Some other methods like the implants, the implants, they actually go under the skin and they release hormones. Those are good for, I think, about 3 years. They're quite long acting. And then injectables, which are also highly effective, those are, I believe, every 3. It depends. There's different types, but every 3 months or every couple months, a woman has to get another injection. So obviously, implants are very effective for a long time. They don't require any upkeep, so to speak. You don't have to keep visiting the doctor very often. But if a woman wants to avoid pregnancy, but not for 3 years, but only for 1 year, then maybe an implant is not what she wants. Yeah, so those are some differences.
Thank you very much. Okay, we have this one coming from 1B Joshua. The question says, how can we combat negative attitude in our local society towards family planning and use of contraceptives?
Yeah, that's the big question, isn't it? that's the single question that, or single problem that every single family planning program has had to deal with. And again, there's no single answer because it depends so much on what's the local institutional framework and culture. But just to give an example, from Bangladesh. So it's not even in Africa, but it's a good example. So in Bangladesh in the 1970s, there was, at that time, I believe the women were having about 5 births per woman. And in Bangladesh, women get married at a very, very young age. The average age at marriage was about 18 years old. And it's a very, very conservative population, conservative Muslim, and there was a lot of, and women did not and still do not have tons of freedom to make these decisions themselves. So when they started family planning programs in these countries, they really focused on earning the trust of the local imams, the religious leaders, and convincing them that family planning is good for the health of the women. It can help families to be healthy and to have some more resources, and this took a lot of time and a lot of energy to convince imams to join their side, but eventually this became one of the key factors behind the success of spreading family planning throughout the country. And now Bangladesh has fewer than 2 births per woman, and a very high percentage of women using modern contraception. And this is not a rich country. This is among the poorer countries in the world. So even there, they were able to, adapt their approach to the local culture and norms, and by recruiting the local religious leaders, able to convince more and more people that this is a good idea. And I mean, like I said, that's just Bangladesh, but it's an example of how kind of adapting your strategy to the local level is important, because perhaps in parts of Africa, it's not necessarily a religious leader who's important. Perhaps it's somebody else. But the point is the same, to try to recruit some support at that level.
Thank you very much. We have another question. So my question is for the presentation midway. All through the end of the century, the biggest percentage of the world's population growth is projected to be from Africa. Mm-hmm. So if Sub-Saharan African, in particular, if Africa Sub-Saharan in particular picks up modern contraception and high rates, will the population growth be retarded at some point in time?
Yeah, certainly. So, when we do a projection, like almost 100 years into the future, it's almost certainly wrong. But it's more, the reason we do these projections is more of a way to understand what are the implications of present day situations on the future. If we see increasing use of modern methods and lower fertility in sub-Saharan Africa, certainly the population growth will be lower and it'll be less concentrated in sub-Saharan Africa. And I can say this about other regions as well. We just assume, based on our models, that, for example, in Europe or East Asia, that we're going to see continued fertility decline, or low fertility. But if there's an increase in fertility in Europe or Eastern Asia, this picture will totally change. And they will be contributing more to the growth of the population. So it's just based on current knowledge. But yeah, certainly if we see more uptake in modern use in sub-Saharan Africa, you'll see a decrease in that contribution across the century.
Thank you very much. Another question says, how can we improve access to family planning services?
Yeah,
This
it's
would be
okay. Yeah, that, these things are, it's a frustrating question because obviously we as individuals, it's very hard for us to affect this type of thing. In some way, these are things that have to be done at through the government, or perhaps at some lower level, maybe not the national government level, but at the state or county government or some lower level of government. Yeah, there needs to be a decision and an investment to, set up services that can be mobily delivered. So you're actually going to the places where the patients would be, to deliver the services they need. I don't know how much of access is limited by the supply of services and the supply of goods, because if there's an issue there with supply, then obviously the solution is to buy more if it's possible, or to train more workers. But again, these things are coming from a higher level. They're coming from the government typically, or a hospital or a health region or something. So it's the frustrating fact about it that there's little that an individual can do probably to improve access, without establishing their own clinic and committing to that themselves, I guess.
Thank you so much, Mr. Joseph Moritoris. It's a great honor it was a great honor to have you here, and we are so educated from what we have heard from you these few hours. We're so happy, and we are grateful you're here. I'm saying thank you for being here. Thank you for spending time with us and teaching us, enlightening us on these issues. So thank you, and God bless.
Thank you all, and please feel free to reach out. I'll share my email address with the SCOPA people, and I'll send this presentation to them. And if you have questions or comments, please feel free to reach out to me.
All right, thank you very much.
Thank you.
So I really appreciate your coming, and it was an amazing presentation. Really much appreciate, and we hope that every single person has gotten something out of this, and we hope to be able to advocate amongst married people the need to engage in family planning, and also try as much as possible to explain to them the importances, such as improving the health of women and children, and that I think that's as much as we can take away from this presentation. So thank you very much.
Thank you.
Over to you, Ada.
Okay, so thank you everyone once again for being here. It's really a huge privilege. I realize that it's a school day, and and it's also very close to time for prayer for a lot of people. And so I say thank you for hanging on. If you're watching through YouTube, thank you very much. So now, like I mentioned in the chat box, if you want maybe something more explanatory with regards to folk methods, then there's something you could send, and we'll send you through the CAMSA mailing list. Then again, if you haven't taken the USAID course, please remember to do so. And I have sent the link or the certificate, so it's something you can just fill. It's 1 minute thing, and that's really there. And we'll be having a family planning guide really soon coming out. So I think it's going to be like a compendium of every single thing you need to know, not every single thing, but a good amount of stuff that is readily available, evidence-based, and really accessible. So at this point, again, I would want to say thank you to our speaker, Mr. Joseph. It's a huge honor and pleasure to have you here. I realize that, again, it's a workday for you, and there's a lot going on, and thank you for being so patient. Thank you for being kind enough to extensively discuss this with us. The truth is, you notice that something kept on coming up every time. What can we do? Because we have a lot of people who are really passionate about what can be done, but they find that they have a lot of limitations now, maybe because of school, maybe because of access to funds or something. So thank you for making us understand certain things. Thank you for showing us the gaps in our knowledge and how we can actually work better and change the society and improve healthcare in Africa. So really, thank you. It's a huge honor for for having you here, and we're really, really grateful. We want to also say thank you to the director. Please extend our warm thanks to him as well.
Thank you.
So thank you. We'll be having the SCOPA live for every single thing, the family planning, food security, academics, and a whole lot of stuff. So please, list. Link to the course. We put it out on the mailing list a couple of weeks back. I could resend it again. You could also find it on the group chat. To everyone. So basically methods, timing, issues, and how to actually provide better access to people. Well, I think that is. Then please check out. Please look out for it. So please look out for it. Please remember to fill the link that has been sent. I'll send it again. It's important because that's how we actually attest that you. Some people are still in class at speaker series. The person who is becoming the director from, she's the assistant director for the MPH program and as well as the organizational leadership. So yeah, and we'll be having our Operation Feed an African Child project starting up by next month. We aim to feed 50,000 children around Africa and reduce food insecurity, particularly among children under 5 years. Everyone, if I have anything to add, my extension. Okay, thank you very much, everyone. I think we can go now. It's very important. Remember to fill the, please remember to fill the form. Thank you very much. So we'll be ending now. Everyone is free to leave. If you fill the form, then that's basically that. Just keep your eyes open on the morning. That's stuff. We are done. No. Yes, yes, we can. We can actually get a copy of the presentation. You said you send it via mail, so I get it and I send it through the Samsung emails. Okay, so I resend the link again. Bye. Good night, everyone. Good night. You fill the form